Good morning. I'm Chaplain David Gonzalez, and we have Dr. Haskovec supporting this presentation. Feel free, Dr. Haskovec, to jump in and make comments as we go through this. We also have a little role play that I decided to do to kind of show some of the like small challenges that can happen. I'm going to talk about bigger challenges during the presentation because it's hard to put that in writing, but we need to put ourselves in the shoes of the person who's being bombarded with information when we come to discuss the subject. So we want to discuss the importance of the out-of-hospital DNR and the advanced directives. They're both confusing and scary forms at a first glance. And filling them out is not the problem. What is challenging is encouraging people who are struggling with anger, fear, and other emotions about the impending death of their loved one or themselves. But before we start, I want to ask a question. How many of us have actually completed these forms? And when I tried to go through it, it was very challenging because you have to think to the future, like especially if you're somewhat healthy, you have to think like, if I was ever in this position, what would I want them to do to me? And would I ever want to be like that in a prolonged period of time? But I'll tell a story. When I was in college, I got to meet the grandson of Gandhi, Mahatma Gandhi's grandson, Arun Gandhi. And he told us the story of how there was a little boy in his town that ate a lot of chocolate. And since people know that his grandfather was very persuasive, they said to him, well, go tell that little boy that it's bad for him that he eats so much sugar. And a day passed, another day passed, a week passed, a month passed, and the boy never heard from Gandhi. So they went up to Gandhi and they said, Master, why haven't you told the young man to stop eating chocolate? And he said, well, how can I tell him to stop eating chocolate if I'm still struggling with that myself? So the point of the story is that if we haven't come to terms with our own mortality, if we haven't thought about what would we do in a situation like that, how do we expect for our patients and their loved ones to consider those issues? And there's also the medical power of attorney that comes up in these conversations. But in these difficult times, the last thing we want to do is a lecture on how to talk to people about upcoming death of someone who's precious to them or of the actual patient. However, it's crucial to encourage families to make decisions that will facilitate a peaceful death and for them not to be stumbling around trying to make difficult decisions at a time of crisis. Most importantly, we need to build rapport with the family or patient and let them know that we as individuals have their backs and we're there to support them through this journey. If they trust us, they will be able to overcome these difficult conversations and will hear us when we tell them that the only way we can honor their wishes is if they put them on paper. They won't get frustrated and shut down the conversation as easily if they feel that we're truly rooting for them. So let's talk about the challenges. So I'm enumerating the challenges of talking to people about this subject. So challenge one, how do we stay calm and collected during difficult conversations? They say that you should use a calm voice and talk slowly, that you should stop frequently and wait for questions, that you should acknowledge their words, but be sensitive and attentive to their emotions and the responses they're giving you, and to validate underlying feelings and emotions. So you know how if someone says, well, I don't want to talk about this, or this is making me sad or whatever, it's easy to say, okay, I'm just going to leave you alone. But the underlying emotion is that it is scary, that it is overwhelming, and you have to validate it. It's like, I know this is terrible. I know this is a very hard thing to discuss at this time, but it's important to open the conversation. Do any of you have examples or questions related to that? I know that people that work in counseling or I'm always amazed with Dr. Haskovec how good she's able to, she was telling me how she switches roles. When she's giving the medical information, that's one role, but then she goes into grief counseling or just support. So to have that ability to really change gears and step back when you feel that the person is overwhelmed. Any thoughts from you guys?
So my example actually happened just this week. I introduced myself to a patient. This is Dr. Haskovec. Introduced myself as palliative care, and his initial response is as well, I know what you're here for, and you want to know what? It makes me feel really down. And I said, okay, I hear you. It can be very upsetting to hear the word palliative care. So tell me more. Tell me why it makes you feel down. And very simple statement, tell me more. Tell me what that means, is a great gateway to opening up a very long conversation. I think I was there for about an hour and a half, but it was what was necessary to talk him through why the words palliative care were upsetting, what made him feel down. We discussed topics like, I don't want to die. I know why you're here. You're going to tell me about hospice, and I tell you I don't want to die. And again, common, very helpful phrases. I hear you. I have not engaged a patient outside of a psychiatric facility that wanted to die. And I'm not here to talk to you about death and dying. I'm here to talk to you about life. I'm here to talk to you about living. I'm here to talk to you about what's important to you. So tell me more. Tell me about what's going on. Tell me what you're struggling with. And so again, I just kept what we call, it's called mirroring, which is using their exact phrases. It's tell me more, tell me what that means. And then again, I hear you. I'm sorry this is frustrating. I wish this wasn't so overwhelming. Those are very common empathic phrases that when you're at a loss for what to say, or when you feel like the emotions have gotten somewhat tense and you can feel the patient or the family member shutting down, it's a way to help open the door. You just need to be prepared that you may divert off into something that you weren't expecting. So it's happened to me before, like, tell me what that means. Well, you know, my mom died on hospice and all they did was just medicate her until the time she died. It's like, wow, that sounds really traumatic. Tell me more. Tell me more about what happened with your mom. Because usually that hints at a grief response, right? Which is oftentimes a complicated grief. And so again, you may end up spending 15 minutes trying to talk through that grief and talk through everything that happened with their mom. And then, you know, rounding back around to what's happening with them, what's important with them, with their goals, and eventually get into how hospice might help with those goals. But yeah, in the end, you just have to be prepared to divert a little bit.
So the second challenge that we come across is how to shift from informative to more comforting ways of communication. And I think the example that Dr. Haskovec shared was, you come in giving facts or scientific information, and then suddenly you hit a roadblock that it is the emotional aspect of people having had a difficult experience. So now you're not only like, here's the documentation, we need to fill it out. Now you need to pause and say, okay, I totally, you know, understand. Like, some people get offended if you say, I know what you're going through, or I understand, because they say you don't understand, you never experienced this. But this idea that you're willing to understand, you're willing to walk in the journey with them. So we have to prepare the person for an unusual conversation. I know it's difficult with everything that is happening, but we had a situation, Dr. Haskovec and I, at the hospital, where we put the person in our quiet room, and it's almost like a little chapel. And I don't know if for some people that can be discomforting, like it makes them feel like, oh, something bad is coming. But for other people, there's a familiar space of something sacred, something special, and that we're coming as agents of someone who's taking care of their loved ones. So we have to take the time to set a time in a space that is going to be quiet and comforting for them to have these difficult conversations. And I know doing it in people's homes, I always tell people that their home is a sacred space. So we have to honor that space and be very attentive in the way that we use that space to have this conversation, and to offer only what we can deliver. So a lot of times I prefer to have a conversation like this in a group setting, or with medical staff and other people. So then their questions can be answered. Because as someone who's not a medic, you walk in and then they start asking you all these technical questions. You can tell them, you know, in your language and what you understand, but a lot of times it becomes kind of like a battle for information. So to have access to a doctor or someone else to kind of also help them through their concerns, and then engage the family or the patient and adapt what they're saying to what are their hopes at the time of death. Because even though nobody likes to talk about death, what would be the best case scenario? In a little bit, we'll talk about a good death, and for some people that's anachronistic or doesn't exist. But when people think of someone died in a peaceful way, how can you incorporate that into the conversation versus it being a traumatic event? And then to be very specific and to use the words dying, death, and died. People use synonyms that they're nebulous, to go with God or to not be with us anymore or something like that. And sometimes when people are being emotional, it's hard for them to have a concrete understanding of what's coming. And then to listen, and not to always think that you have the magical word that is going to appease them. So sometimes we have to listen more than we talk. But I know when people get nervous and they're put on a spot, you start saying a lot of stuff, and it can kind of aggravate the situation. And to allow the silence to be longer than our comfort level. Sometimes if it's quiet for too long, we feel antsy. To be quiet on the side of the person who's receiving this information is not bad. We need to allow for them some time to process their emotions and to honor our own emotional overload. We have to come to terms with our own issues about death and how that makes us uncomfortable, so then we don't dump that on the person we're talking to. Any thoughts? I think we're going to move on to challenge 3. How to talk about...
Hey, David.
Go ahead.
I have a question. Hey, we would like some advice on how to get the patient to express their goals and what they want during that time, or how they want that to go down. A lot of times it's hard to get them to talk and express that. There may be a family member that does all the talking, but for the patient, when the patient's really able to express that?
Well, there's a lot of family challenges, and that's the biggest problem. So if there's already like a protector, in every family you see different individuals who take different roles. So you have the one guy who freaks out and leaves and is not involved in the process. Then you have the one who's like the leader and is like, tell me what's going on and I'm gonna make things happen. And like they have to stay busy to not deal with their emotions. Then you have the people who are completely like numb. And then you have the patient who could be somewhere between all those. So when you have someone who's overpowering and they're like, well, I know that they want to live forever and I don't care what anybody thinks, they're going to be all right. And, God has them, in their plan and this and that. Like you have to break through that and not automatically be shut down. And then you also have to, we've all been in a situation where you start talking to someone else and the patient is in the room and they get mad and they're like, I'm still here. But sometimes they haven't expressed that until you get there, and the family has been kind of guarding them from the truth and what they're experiencing. We can't talk about it in front of them because they're going to get depressed and then they're going to die quicker, or stuff like that. You see that in Latino families. So I know it takes a long time, and I've helped with some of the patients in your service where it took like 5 visits to build that type of rapport. And I'm a minister. I was gonna joke that when Dr. Haskovec or I walk in the room, we have certain abilities just in rapport, like it opens the door to have a title behind you, because depending on what kind of experience they've had with doctors or with ministers. So when someone comes in and you're reading the room and you're trying to understand who's in charge here and who's the one pushing their agenda, you have to be able to kind of disarm their assumptions and the barriers they'll build to not even discuss the subject. So it's a long process, but I know that the nurses and the techs have that relationship, and that's what I love about home health and hospice, is that you have the ability to build that relationship in their own homes. So then you start knowing kind of the dynamics, and then you can kind of plant the seed and kind of prepare them for those bigger conversations. Sometimes you don't have time because it's a quick turnaround of events, but you have to kind of like be invested for them to even be willing to tap those subjects. And when there's people who are purposely manipulating or trying to get you away from the conversation, you have to kind of like bring it back to why are we all here to begin with? We're trying to come for the patient. We're trying to help the patient have the best outcome as well as the best experience at this time. So to be reminding the family, like, we're not trying to cause more friction or more anxiety. We're trying to help process it. But that's where you need a social worker, a chaplain, and other people from the team to come support you, because sometimes you by yourself might not be able to get to that point. But if we all have the same message and we're all working for the same goal, then the family can kind of open themselves up while we're going through this.
So I'll give you my 2 cents as well. What I highly recommend is, number one, always engage the patient initially in the discussion of planning the conversation. It's a very simple statement of, we need to have a conversation about your medical care, about your potential future medical care, and how you would like to control what happens to you in the event that you cannot speak for yourself. And you can clarify further with, that's using things such as advanced directives, a medical power of attorney, or a living will. So you can start with that, and then generally, depending on their response, you go further based on what they say. Well, I'm not going to talk about that right now. Very easy. Tell me more about why that's not a conversation you're willing to have, or label the emotion. You seem a little frustrated by or flustered by my mentioning these documents. Tell me about that. The very easy way to, again, get into, dig deeper, find out kind of what's going on, and eventually get around to it. When you're posturing this conversation or setting up this conversation, we need to have this conversation about A, B, C, and D. Who needs to be involved in that conversation? And the patient will say, my daughter, just ask her. She's in control of everything. That's actually legally binding, in a sense, that the patient has now told you they want you to tell their daughter. And you can clarify that further with, so if we need to talk about your diagnosis, your medical care, if we need to talk about procedures that you need, are we talking to you or we're talking to your daughter? Talk to my daughter. My daughter does everything. I don't want to be involved in any of it. Just let her tell me. She will tell you what to do. That's actually legally and ethically binding. You are then no longer supposed to talk to that patient. You should not be telling that patient they have cancer, and if they don't already know, you should not be telling that patient their procedure options and then consenting them. They have told you they refuse to. So the key is always, who should be involved in this conversation? Do you want to be involved in this conversation, or is there a family member that you want me to talk to? Which, if they then go, well, yeah, talk to my daughter. My daughter's in control of everything. Okay, well, in order for us to make sure that your daughter is in control of everything and can do all of the things you're asking for, we need to fill out a medical power of attorney. And you do have to sign that document, and we'll run through that document. We don't have to give you any diagnoses. We don't have to tell you anything about the procedures that you're going to need or not need, but we do have to have you sign that document by yourself. Your daughter can be present and others can be present, but you are the one who has to sign that document. So the key is set up, right? Introduce the idea and set it up, right? And that may not be a conversation that you have during that visit. You may have to set up a meeting for next week or the week after, or later that week, to have that person present either by phone or in person. So that's always the first step, is to introduce the idea that you're going to have this conversation, to ask who needs to be involved in that conversation and if the patient wants to be involved. The third thing is firing what they call a warning shot. So the warning shot is a very, very good tool to use actually in everyday life. If I can give you a silly example, it's, honey, I understand this is a tough day. We're both very tired. Unfortunately, I'm going to need your help, right? It's warning shot. And then I'm going to give my loved one what help I'm going to need. I'm making dinner. I need you to unload the dishwasher. Very similar for a 3-year-old. I'm giving you my life examples. I know it's really tough for you because you have to go to school today, and I'm really sorry. However, I have bad news. You have to wear pants to leave this house. And so you get a choice, blue pants or red pants. But I can't let you leave without pants, because no one wants to see your private parts. So it's silly, but that is how you do warning shots. That's how you do giving choices, because when you're asking a patient to tell you what they want for their medical care, I do not recommend leaving it completely open-ended unless they're very clear. You know, with the patient I actually worked with earlier this week, who was initially very resistant to talking to me, I did actually leave things relatively clear, open, and he gave me what he wanted, and then I was able to tell him medically what that would mean. But if they're not being very clear, you can set things up for them. So respecting choices has a very nice setup, which is 3 different goals or 3 different priorities for medical care, and then 3 different types of medical care that would fit those goals. So the first goal, or the first, I guess, priority for a patient's medical care, which is ideally what the patient would or family would give you. They may not, and if they don't, you can supply these. The first one is basically sustaining life despite any pain, suffering, and with all means necessary. That is one priority that patients or families will have, and you need to vocalize that. It's okay to give that words, because when they say, well, do everything, right? So do everything, well, you're going to do everything, right? Then you have to ask, right? Well, tell me, what does everything mean to you? Because I may have a different understanding. Tell me, what does do everything mean? But again, that's one priority. One priority is sustain life by all means necessary. Is that really the best priority medically? I can't really say yes or no, but when you're giving this family priorities, that is one priority that you can kind of offer to them. The second priority is to maintain your current health, maintain your health, but avoid overly burdensome interventions, procedures, and treatments. So that would be things like breathing tubes, breathing machines, potentially dialysis, a feeding tube, and that's where you're going to go into more specific details. But in general, that's again how you would broach that is are we wanting to maintain our current health and have a chance to improve while avoiding overly burdensome? Sometimes I've had patients talk about cost. I do not bring up cost. They bring up cost. And then I will speak to cost because it is a goal or a priority for them. But in the end, it is about, again, what is a burden to them? And when you bring up that burdensome topic, you want to say, what do you think would be burdensome? What have you seen, or what do you feel is something that you're not willing to undergo? Again, the example for the patient that I just saw was, he said his priorities, his goals was to get home. I want to get home. I want to be with my family. I do not want to be here all alone in this hospital. And even though he had said, I don't want to die, he was very clear on, I need to get out of here. I'm not willing to stay here forever, which if he wants to be kept alive forever, that's unfortunately what it would mean. And that's what we eventually got to, because I brought up, well, what does it mean to you then if they put a breathing tube in your mouth and put you onto a ventilator? And he goes, well, why would you do that? Then I wouldn't be able to see my family and I wouldn't be able to go home. And I said, exactly. That's the truth. I hear you in that. It's very important that you be able to be at home and be with your family. And so I think that means being prepared for, if things happen, we need to have a plan for worst case scenario. And I didn't have to go into, because the worst case scenario is what's going to happen for you. I just needed to say, we have to be prepared. And I need to make sure that your family's prepared for this as well, so that we're all on the same page. And then, of course, the third priority, or the third option for goals is I want comfort at all costs, which is I just want everything 100% on focus to keeping me comfortable. I don't care to live longer. I don't care to, be here in this hospital. I really don't want to be in this hospital. I just want to be at home and I want to be comfortable. So again, clarifying with them what that might mean, right? So that might mean, being on hospice. That might mean staying out of the hospital. That might mean no machines, no tubes or artificial life support. And that would generally mean allowing a natural death, which means no medical interventions at the time that you die. So that's, again, if you're helping them talk this out, that's what you as a medical provider can give to them, as in general, the general 3 sort of priorities that patients can have. Live longer, whatever that means, whatever that takes, live longer, but you need to ask them to clarify what that means, right? Well, I want to be driving my car. Okay. So if you got to the point where you couldn't drive your car, what would that mean? Well, I wouldn't want to be kept alive like that. Okay. So let's talk about that, right? The second priority is maintaining my current health. Well, I don't want to die. I want to stay alive. But I don't want anything that's going to keep me from going home. So I'm okay with the interventions they're doing now, but I don't want anything more than what I have now. And then again, clarifying what that means further. And then that third priority is I really just want to go home. I don't want to be here anymore. I'm ready to be comfortable. I'm ready to go. I'm ready to die, which is totally a fine statement to say. Again, if you're uncomfortable with that statement, take a break, take a pause, and then ask them to tell you more. Tell me more about what that means. You say that you're ready to die. Tell me what that means. So you get your priorities, right? You ask them to pick a priority. And then once you have one of those priorities, you then should ideally clarify, if they're not clarifying it for you, what that means as far as medical treatments. So for medical treatments, there's 3 options. Full treatment, which is, again, sustaining life at all means necessary. The second option is selective treatment, which is maintaining current health and avoiding overly burdensome treatments. And then the third option is comfort-focused therapy, which is 100, maximizing comfort through symptom management and avoiding the 2 other categories, basically. So when you clarify that, again, you actually want them to try to give you what they mean. Well, I've been in the ICU before and I'm not going back to the ICU. Well, tell me why. Tell me what happened in the ICU and why we wouldn't want to go back. Well, and then they'll give you the story. And then at the end of that story, if you haven't had anything else that you've had to delve into, or even if you had, you want to bring it back around, you say, well, I hear you say you don't want to go back to the intensive care unit. And I think that's actually very reasonable because, to be honest, medically, the intensive care unit is only a place for machines. So if you go back into the intensive care unit, that means machines for you. And it doesn't sound like, based on your conversation with me, that that's really the life that you want. So if we can keep you alive, you want us to try, but you don't want us to go to the point that you're stuck in a bed on machines, unable to care for yourself, 24/7, dependent on someone else to keep you alive. Oh no, of course that's not what I want. And so sometimes, again, that clarification is really what that need and that guidance. Because when they say do everything, you have to remember that phrase comes from a lot of different places. It comes from guilt, it comes from grief, it comes from anger, it comes from sadness, it comes from love, it comes from unfortunately sometimes less than ideal motivations such as money. But wherever it comes from, you have to keep asking them to tell you what it means. You have to keep asking them to delve in deeper and give you more information. So that's, again, when you're having those struggles with someone, you're trying to get the patient to do this conversation. 1, set it up. Ask, explain that you would like to have this conversation, that it really should be done to protect them. 2, ask who should be involved in that conversation. And yes, they do have the legal wherewithal. They do have a legal standing to say they don't want to be involved in the conversation. They refuse to know their diagnosis. They refuse to consent for procedures. They refuse to do all of these things. It is on another family member. And you have to then explain, in order for that to happen, I need you to sign this medical power of attorney. I need you to sign this document, because legally, if you do not, it's going to fall to A, B, C, and D, or whoever else is going to fight for it. And I don't think that's the best choice for you. And then again, that third thing is when you're struggling with, well, they won't tell me what they want. Try to go back to what you know. I hear that you really enjoy being with your grandchildren. So if a medical intervention would leave you unable to be with your grandchildren, would that be okay with you? So go back to what you know. And if you don't have anything to go off of, then give them those 3 priorities: living longer, maintaining your current health, or being completely comfortable. And then take those priorities and put them down into medically what that means: full treatment, selective treatment, or comfort-focused treatment.
Thank you, Dr. Haskovec. We're going to move to the challenge number 3, and this is if the person is incapacitated. So now we're talking to the medical power of attorney or the rest of the family as we're trying to shift the conversation from extending a life and pain and discomfort to quality of life. So as we delve into the issue at hand, we ask poignant questions such as, did he or she say what kind of treatment they wanted if they ever ended up in a hospital? People usually don't want to make the decision themselves, so you have to go back to some old conversation they had with the patient about this type of situation. And at first they'll say, oh, I can't remember, or we never talked about it. And then the more you dig, the more it comes out that they had a loved one, especially if they're elderly. They've had some other member of their family who was in a similar situation, and they said, I never wanted to be like that, or I would hate to be stuck in machines. We also have to communicate how this process of discussing the fate of the loved one is not about giving up or losing the impetus to try to help the person. It's about realistic expectations. And that is why I never talk about miracles, since that's outside of our level of expertise. And even me as a pastor do not understand how that stuff works. So we have to kind of keep it within a medical framework where what are the expectations when someone has a stroke, when someone has a heart attack? What is likely versus some random thing that could happen that is out of the ordinary? Because that's something that we can't really process or discuss much. And then describe to them what quality of life is. The definition of quality of life is the perceived quality of an individual's daily life, that it is an assessment of their well-being or lack thereof. So for example, like Dr. Haskovec was saying, what do they enjoy doing? What could they not live without? And sometimes it seems a little cold, like, well, if you're not able to enjoy comic books or TV shows or whatever, then that means that you don't want to live. And it's like, no, it's about their ongoing interactions and the ability to live a life to the fullest. And we know that some people have been sick for a long time and they haven't been able to live their life to the fullest. But now we're talking about impediments to their well-being. So that's the hardest part to convey when we're talking to people. And then sometimes we have to discuss what a good death is. So the definition of that is basically a model in which the dying, the family, and the professionals all work together and support each other. However, most people are only concerned about themselves, so it's a huge challenge to overcome to think about, well, we want a good death to be where the doctors, the nurses, the family, and the patient are all in unison and they're all working together. But we know that when you ask someone what is a good death, they're going to say, well, what's specific to that person? And they might not be aware or concerned about what everybody else is experiencing. So again, it's about working as a team with the patient and the family, where we're bringing a peaceful resolution to someone's ongoing struggle versus pumping someone with so much like support that is a time of crisis when they die, and it is a traumatic experience. And so that's why I like to talk about a peaceful transition. Since most people believe in a type of afterlife, it's not easy to talk about the subject, even with religious people, but we talk about allowing nature to take its course, and sometimes it's difficult to even broach that subject. But I feel that for humans, our sense of self-preservation is so great that we rather deny the truth of our own mortality than to face it head on. Even when someone is elderly, even when someone has been sick for a long time, to even broach the subject it can be earth-shattering. So we have to just build it with time and have the sensitivity to see if they're even willing to go there, but not take their frustration or their lack of interest at that time as, well, we're never going to discuss the subject anymore, because it is our responsibility to be straightforward with them. Any thoughts? I hear some noise in the back. I don't know if some of you guys can mute yourself. And we have 15 minutes, so I want to move on to the next two challenges, and then we're going to do a quick role play. Challenge number 4. Let me see if I can. Challenge number 4 is how to talk about what would it look like if to not seek aggressive measures and what the treatment would be. So that's Dr. Haskovec already discussed that. And if we talk about supportive versus aggressive care, we open the door for them to connect the dots. So like I've heard Dr. Haskovec make a distinction with the different types of care. That's how you're able to bring the conversation to the place where we want it to be, because now they can see the difference between people that are already in a bad place and they keep pursuing the same type of care without any change. People think that is like a magical thing. You do these things and the person gets healed. Well, the person is such in bad shape that they don't have the ability to heal, that no matter if you keep following the same path, you're not going to get different results. And then we need to be well-versed in palliative and hospice support so they know that we're not stopping care for them, but we're giving them more specialized support. So that's the thing about comfort measures, where we're able to zone in on what they're really feeling versus trying the same thing that doesn't address those specific needs of that patient. And then challenge number 5 is how to be brutally honest and kind at the same time. We sometimes need to ask them, what is your fear? What do you think we are saying? Kind of like what the doctor was saying, that if they tell you, I don't want to talk about that, or it's not a good time, you inquire why. And, you're building a relationship with them by asking those poignant questions. But if they truly feel your interest and that you're listening to them, they will go there. Sometimes they might react negatively or be frustrated, but they're engaging you. And I think engaging someone is more important than being dismissed. If someone says, just walk away, I don't want to talk to you, even then they're telling you something. They're telling you that at that moment it's too much for them. So just to keep building on that relationship is important. And then to encourage questions even when there's no answers. Allowing them to process what they're going through and say, that's a good question. What do you think? Because if I had a lady ask me, do you think that what I'm doing is wrong? She wanted to let her husband go. And the other family members weren't sure. And she asked me, do you think it's a sin for me to let him die? And then you can turn around and say, well, what do you think? Because, then they say, well, the pastor told me it was okay. But to open the door for them to process it and to think within the terms of their own religious tradition or their own ethical system, that is important. Because, again, we want to guide them and support them, but we don't want to dictate. So we just want to give them the information so they can make the best decisions. And when they get rattled, don't let them rattle you. So sometimes if you're having an intense conversation and someone just gets really frustrated, then you get frustrated and you don't know what to say, and then you're scared you're going to offend them, and it just throws you off. Just know that it is going to be a difficult thing. And with time, you kind of become more comfortable with those conversations. And it's not about being numb, but it's about managing your own concerns and always keeping the goal in your mind. Like, I want to help this person have a peaceful death. I want to help this person transition in the best way possible. So don't let anything throw you off, and be aware of common responses. So like she was saying, I want to do everything possible. I don't want you to give up on them. So we had a circumstance where as we were talking to the patient's wife, I shared with her that the machines were doing all the work, that he couldn't, he had been through so much, but he couldn't overcome the illness. And she said, well, what you really mean is that you're giving up on him. And at that point, you take a pause and you say, that's not what we're saying. What we're saying is that he's reaching the limits of medicine and reaching the limits of what his body can take. And the thing about planting a seed, sometimes it takes a while to get the conversation going. and we have to validate their emotions and be genuine and honest. I think people will appreciate that. And consider the cultural ramifications of groups that perhaps are more inclined to do everything when they can for the patient. But we can't stereotype, certain groups, religious groups or ethnic groups, they're always trying to do everything medically. I've seen people from every walk of life take that path, but like the doctor was saying, maybe they don't even know there's other paths. Maybe they don't even know that there's other options. So we have to make them aware of them. Doctor, do you have any thoughts?
No, that's right.
So we're gonna move on to a quick script. I try to make it a little funny to keep people awake. So Dr. Haskovec is gonna be Annie, the patient, and her aunt Linda, and I'm gonna be the person who's the facilitator to talk about advanced care planning. So action. Hi, I'm David. I'm here as part of the team to support you the best way I can.
Hi, David. I'm Annie. So what's up? What's going on?
I'm an advanced care planning facilitator. I would like to discuss with you future healthcare decisions. I know you're going through a lot right now, but it's time to write down your medical goals, values, and preferences and designate a person who can speak on your behalf. So here I say that, if you present yourself as I'm Dr. Haskovec or I'm Chaplain David, you might have like a little in. But if you're just any healthcare professional and who's talking about advanced care planning, they might not even know what that means. So you might have to explain yourself a little bit. Go ahead.
Right. So why are you bothering me? Don't you see, like, I'm sick. I'm going through things right now.
Well, my role is to give you all the information to help you make the best decision and for your loved ones to speak on your behalf if you're not able to do so.
So you're talking about like my family, already dividing the spoils of my death. Like, I'm still here. I'm sick, but I'm not dead.
I understand you're overwhelmed, but one of the most important decisions to make is who do you trust to represent you? Who do you think will accept the role? Who will honor your goals, values, and preferences? Sometimes we pick someone who's not overwhelmed in a time of crisis. We need an impartial decision maker when bad things happen.
If I'm honest with you, I don't trust anyone in this family, man. I feel like they're all probably trying to go after my money.
Do you understand that you need someone to make decisions for you in difficult times?
I mean, I guess so. Like, maybe they keep everyone from stealing my money. If it had to be someone, it'd probably be Aunt Linda.
At this time, what do you understand about your condition, your medical problems?
Well, I know I'm old and, probably not going to be around much longer.
Has there been any changes in your medical situation?
Well, I had that stroke like 3 months ago, which is why, I think it's, potentially not going to be long for me.
So what problems do you think you might have in the near future?
Well, I remember the doctors telling me I could have another stroke. I might not be able to talk anymore. I might not be able to walk anymore if that happened.
And so what's your biggest fear if that were to take place?
Well, not being able to talk would be pretty terrible. Like, not being able to interact with my family would be really tough, because even though, I joke like they're going to steal my money and I don't trust anyone, they're my family, and I don't want to be alone. I don't want to be stuck, unable to engage with other people. That just would not be good. I don't want to do that.
Have you ever considered what a peaceful transition would be like?
Peaceful transition. You mean like dying? You mean like dying, without pain?
Yes, dying without suffering.
Yeah, I mean, I obviously, I don't want to be stuck, unable to engage with my family. That would probably be suffering. So I guess that would be a nice way to go, without any pain or suffering.
A reason for discussing paperwork that expresses your wishes is the fear of you suffering a severe permanent brain injury and not having the ability to tell us at that time what are your wishes.
So you mean like the stroke where I wouldn't be able to talk anymore, so I wouldn't be able to communicate?
Yes, and I also want to share with you about making an informed decision about CPR.
Oh, you mean that thing like in the movies where they like pound on people's chests and then you come back like good as new? Everything's okay?
I know it's a lot to process, but movies are not accurate depictions of what really happens. So then on Linda walks in.
Hey guys, what you talking about?
Well, we were sharing with Annie about how to make her wishes known and how to get that written in paper so people can honor her wishes. And she has designated you as the responsible party. I would like to help you understand what this document means. And if you have any questions, I would like to answer them.
Can't you see she's really tired? What is this piece of paper? Why are we doing this now?
It's an out-of-hospital, do not resuscitate form. It tells healthcare providers to not perform CPR if she has stopped breathing or her heart has stopped.
Well, but I want everything, like the whole works. I want everything.
So that's Annie talking again. And then my response, the EMT team will perform cardiopulmonary resuscitation, it's EMS, which can cause trauma for the patient and the family witnessing this. When the paperwork's in place, we call the home health team to help her ease the symptoms and to help the patient transition peacefully.
Annie, you know, you don't really want them hurting you like that. You've been through a lot. Maybe if it's your time, they shouldn't do that.
Well, I can feel this is a very difficult decision and discussion for both of you. Then Annie responds.
Yeah, I mean, you know, nobody really wants to talk about death. It's not nobody likes talking about that. Yeah, but I'd rather have some say in what happens to me when I pass. So go on.
I know this is very overwhelming, and all we want to do is honor your choices. There are many patients that sign the out-of-hospital DNR, and the family still calls EMS. That's why we want to make sure everyone involved agrees with this approach. So then Linda responds.
Yeah, I'm not having this conversation. Annie is staying with us for a long time.
So when they respond with anger, resentment, or sadness, we stop. We do not keep trying to barrel through the speech. That's what people often do. We take a pause and acknowledge what happened and try to put yourselves in their shoes. So on Linda, I can see this is really frustrating. How can I be more supportive?
I wish you would just stop talking about death. I mean, she's not going to die. It's not going to happen. Hold on. You know, I did have that stroke 3 months ago, and I know I'm not going to stay healthy forever because I've already been through the stroke and I got better, but I don't know. Maybe this young man is just straight shooting with us, which I really appreciate given everything I've been through. So I'd like to hear what he has to say.
So we want you to be in control to make the right decision for you. On Linda, I know loves you and wants to honor you. And it is important to have a legal document with your wishes. If this doesn't happen, someone is going to call 911 and they're going to come, they will press on your chest and take you to the hospital. And that possibly might be your last end of life experience. You would undergo this trauma of the experience, and the likelihood of you surviving is going to be very low. So you don't get to die at home, as you have made your family and friends have told us that you want to be peaceful at your own home when this happens.
So what's in it for you? Why have this conversation?
We just want the family to be there for you instead of you being isolated and full of machines at the hospital. When we know that being at home is what gives people comfort, so we want to make an opportunity for you for your wishes that you have told us, that you want to die at home, you want to be surrounded with your loved ones. Even now is a difficult time where there's few visitors. So it would be a very challenging thing if you were to go through the whole aggressive procedure of trying to bring it back.
Okay, so what do we need to do to get these forms done?
So the paperwork brings about the results that we're talking about. And that is why we call it a good death, because it's a death that honors your wishes, where you have the people that you love around you, and where it's a transition that is peaceful instead of a crisis or a traumatic event. So we want to facilitate that for you. So then it's, so I guess you can ask, what is a good death?
Right. So what do you mean this thing, a good death?
So we know that sometimes prolonging life is not always the best option. So this goes back to our conversation that we had, is that unless they know that there's different options, unless they know that aggressive treatment is not the only way to do things, then you're giving them other alternatives. And when someone is very sick or has had multiple comorbidities, or their body's shutting down, is it really the best idea to prolong their life? So any thoughts? We can unmute everyone, but you saw us doing improv. I'm trying to unmute you.
Improving these conversations is very difficult, because generally we are not in those emotional moments that most of our patients and families are, but we do try our best. And it's a little awkward. We understand doing these simulations is very awkward. I've watched lots of simulations with like the professionals in palliative care who have like been doing this for years, and they're very awkward to watch, even for me. So please don't be embarrassed if it's like, that was awkward.
We know your time is precious, so we made it in an hour. Is everybody doing okay?
Yeah.
I can't unmute Mama's tab.
Any other challenges you guys have faced that you'd like some tips on? Again, I've probably heard it all. I've been called a murderer. Like I've heard it all. So if there is something I can help you guys understand or give you a tip for how to manage something, I'm happy to do it.
I think, Dr. Haskovec, it just basically takes practice. Obviously, you guys have a lot of practice, and we just need to kind of set a goal for each time that we see our patient, that we just, open up that conversation with them, so that we can learn. Yeah, so that we can learn. You're going to get all different kind of responses from people. And family members, and that's going to help us learn to react appropriately to get the most out of that patient. I feel like that's what I need. I just need, more experience being out there and discussing that. And our poor nurses are out there hoofing it. They're all maxed out, on their schedule, and so that they don't have much time to do that, but that doesn't mean that they don't have 2 or 3 minutes during their visit to just address that with the patient, especially our LVNs that are in there every week, and sometimes they're in there every day. So that really gives them more of an opportunity to follow up on the conversation.
Mm-hmm.
And gain that experience.
Yeah, and it's okay to chunk it up into pieces too. Probably the best thing for you guys is recognizing opportunities, right? I don't want to do this anymore. Do not run from that. That is an opportunity. That is an open door. I highly recommend you walk through that. Tell me what you mean. I'm so sorry. This is really difficult, and it's okay to tear up. It's okay to cry. I've been with you for the past month, and you're struggling, and I know this is hard. Tell me what you mean. So you know, that's an opening, and you can do a 5 to 10 minute conversation right then and there. And then you can come back later at a later date and go over other things with you. You know, last time we talked about how you don't want to do this anymore, and that's okay. You mentioned that your goal was whatever their goal would be. Maybe it's time we talk about advanced care planning, advanced directives, medical power training. Like, there's a way you can bleed everything into these conversations, and you can do it one piece at a time.
Yeah, and it just takes the family or the patient time to digest those things. It might be 4, 6 weeks or months before they really thoroughly digest it, internalize it, and can make a decision.
Right.
I mean, I've just seen that over and over again with this patient and our nursing staff, you know, out there and like going back and forth with the family and them trying to decide if they're going to go hospice or palliative, or do they want to keep doing this? And when that same nurse is consistently out there, it makes it easier on the family. And I've seen them transition and go to hospice totally appropriately, but the family, you know, to my delight, were very pleased with having the support for home health before that, and it helped them make that decision.
Right.
It's hard for me being in the office to have that personal contact with them over the phone, but I see our nurses doing that, you know, every day.
Right. Well, and that's why, again, you have a team set up here. So if you do have that, I don't want to do this anymore, I can't do this anymore, address it in that 5 to 10 minute intervention in the home, and then refer it to someone else to follow up on, right? You do have a chaplain who can come by. You have David. You do, even though, again, it's harder to have these conversations by the phone, they can be done by the phone if the patient and family are willing. It's okay to say, you know, we have extra support in the form of Teresa, our case manager, who would be happy to chat with you by phone to go over kind of everything you're dealing with and really talk about, you know, what's important to you. So that conversation can be done with, you know, your whole family present or whatever. You can even be there to facilitate that. Hey, how about we call Teresa and have Teresa in on this conversation? So if you have someone who's really good at the conversation and really interested in doing these conversations, I don't recommend squeezing that person until they're dry, but I recommend really using that person, and then you learn from that person, right? So as human beings, we learn to mirror and mimic things a lot easier than we learn to build them on our own. And so watching someone else do it and then having that guidance and that mentorship is very important. But that's why the patient simulations can be helpful. They're not perfect because they are slightly awkward, but they can be helpful to watch a patient simulation.
And sometimes it takes a setback for family to even get there. So if you've already introduced the idea of having advanced directives or out of hospital DNR or medical power of attorney, then the patient has a change of condition and they already have it in their mind. It already, like, they need that to be the push. So, but one thing I was telling Allison is that for some people, you have to chase them around to get these forms completed. And I know the out-of-hospital DNR is very complicated because it has different sections and people have to sign in different places. So sometimes you actually have to take time from your day to drive around to get it to everyone and then get it signed by the doctor. So I think that's the challenge. Like, we all have so many responsibilities, and then the families get kind of numb or so overwhelmed that unless we push and unless we keep the plan going and guide them through it, it's easy to kind of put it aside and dismiss it because it might be too painful or it might be too much, overwhelming to do. So we need to stay cool and collected and help them navigate all that.
So the last tidbit I'll leave you guys with is something I was teaching residents before I left the hospital that I used to work at. So there was a chaplain who presented an article, produced an article regarding what was called the Amen Protocol, which is a way to handle statements from families that are along a spiritual realm of, well, we're waiting on a miracle. Well, it's in God's hands and God's going to do a miracle. So I've actually, I modified it just a little bit, and basically I'd recommend you guys use this at all times, again, in all parts of your life, work and personal, when responding to emotional, difficult, rude, insulting, or, you know, hard to hear statements that people might make. Again, the joking statement is, I'm not gonna put on pants, which is my 3-year-old. So the AMEN protocol is acknowledge, meet, educate, and next steps. So the first step is acknowledging or labeling the emotion that you're hearing or the statement that you're hearing. Again, using your mirroring skills. It sounds like you're frustrated about putting on pants. The next one is meeting them. I understand being frustrated that you have to put on pants before you leave the house. Educate them. However, in order for us to go outside and play, we're going to need to put pants on. Next steps. So I have a pair of red pants and blue pants. I need you to pick a pair, and then we can go outside and play. So that's it's a very easy tool to use. And when you have those moments where someone hits you with something that you just are like, and you catch your breath and you feel your heart race and you tense up and you're like, you have your own emotions about it, what I recommend is fall back on that. And you can use that for everything. I hear you're angry. You have a right to be upset. It's okay to feel that way. However, and I recommend using however over but. Again, there's just something about the word but that people take it a little emotionally. So however is helpful. However, we need to blank, or we have to blank, or in order to reach your goal, this is the only option we have. So moving forward, ABC. So with the miracle statement, it is, I hear you. Faith is very important, and having hope is extremely important, because with everything you're going through, it can seem like the information you receive is without hope. And so I'm glad that you have a belief in better things, because that's really what we all need. However, as your medical provider, I can't speak to what a miracle might look like, or what a higher power, God, whatever words they've used, might have planned for your loved one. So moving forward, I can only give you the medical information, and then I have to ask you to take that information and tell me what you think we need to do based on what you believe spiritually and religiously. And our options are, and our current medical knowledge indicates, you know, whatever it is, which is usually that this is not going to go well, and that unfortunately this disease is likely to lead to the end of your loved one's life. And so if that's the case, what does that mean for their medical care? What does that mean for their priorities? Would they be someone who would want to live longer no matter what happens, no matter the pain, suffering, or procedures they have to go through? Would they be someone who would be okay with certain interventions that are aimed at maintaining whatever health we can maintain, but they're not really interested in being permanently stuck in a bed, permanently on machines? Or would they be someone who would tell us that they would rather be comfortable, they do not want to be kept alive like this, and they would rather for us focus on letting them go? And so again, you see I'm using my priorities, right? I'm laying my priorities in to this AMEN protocol. So acknowledge, meet, educate, next steps. It's a very, very easy tool, I think, to use, and I use it as much as I can. I don't use it very well in my family because I get too emotional. I can't control my own emotions. But if you can pause and breathe and then remember to go back to acknowledging, meeting, educating, and next steps, you will be much more successful in these conversations, especially when you hit walls, especially when you hit statements that are, I'm not going to do this, how dare you talk about this. When you hit those, acknowledge, meet, educate, and next steps. And be prepared to divert, again, into any grief conversations or other support conversations that need to happen. And be prepared to delay. Well, my daughter really needs to be here for this. Okay, well, we can call her right now, or do you want me to set up another time that I can call you both, have you on conference call, or I can be here in the home and we can meet with your daughter in person? You tell me what works best for you and your daughter. Well, I'll have to talk to my daughter. Okay, well, I'm going to call you tomorrow and I'm going to find out what you guys want to do as far as having this conversation. So just let me know. Or tell your daughter to call. If your daughter doesn't call me before tomorrow, I'm going to call you by 3 p.m. tomorrow. So again, setting that expectation of the next step, that's the way you get around, well, we'll just do it later. If you don't push. You don't want to be mean or insulting, but if you want to offer this option of, hey, I will take my time out to do this for you, it can be very helpful. All right, that's all I have, and I have another meeting I have to get to. Sorry, guys.
Thank you.
Bye.
Thank you, Dr. Haskovec and David.
No problem.
You guys have a good day.
You too. Good luck out there, guys. Y'all stay safe. We're praying for you.
Thank you.
Thank you.
Bye.
Take care.